Good morning, everyone. I'm Dr. Radhika from the medical team of CIPLA, and a very warm welcome to you all for this webinar, the Diabetic Lung Chapter 2. And today we'll be talking about management of diabetes and tuberculosis. We'll also be discussing some interesting clinical aspects as well at the end. And to talk about the same today, we have two eminent speakers. And before we begin, I would like to hand over the session to our moderator, who is Dr. Vijay Vishwanathan. He doesn't need any introduction. He's an eminent personality in the field of diabetes. But I would like to introduce him. He's the head and chief diabetologist of MD Hospital for Diabetes and Professor MD Vishwanathan Diabetes Research Center, Royanpur, Chennai, a WHO collaborating center for research, education, and training in diabetes. He's the president of D-Food International based in Belgium and consisting of experts in diabetic food. He's the national vice president of RSSDI. He has more than 30 years of experience as a diabetologist. He's done PhD in diabetic nephropathy from the Dr. MGR Medical University from Tamil Nadu. He's been the recipient of the first Vivian Fonseca Award for the ADA for the research paper on diabetes and tuberculosis in 2013. He's published more than 200 original research papers in diabetic food, nephropathy, diabetes and TB, and socioeconomics in diabetes. So with that, I'd like to hand over the session to Vijay Vishwanathan to take this forward. Over to you, sir.
Yeah, thank you, Radhika. You can maybe stop the slide share for 1 second. So
sure, sir.
10 seconds, yeah. So I think we always talk about diabetes in the heart and diabetes and the kidney, but very rarely we talk about diabetes in the lung. So I think today we have a different topic, a new topic. It's not a new topic, it's a different topic. And we have two experts, one pulmonology expert, Professor Christopher, and Professor A.K. Das, who's a doyen in diabetology and endocrinology from country, so to speak. And the first talk is by Professor Christopher. And can I have the CV now, Radhika? Professor Christopher is the Professor, Department of Pulmonary Medicine, Christian Medical College, Vellore. He's a co-director of the Diploma in Allergy and Asthma program, and the only formal training program in the field of allergy in India. He's a past president of the Indian Chest Society and the Indian Association of Respiratory Care, and he's a chair of the research committee ICS. And his name is listed in the top 2% in 2021, according to Stanford University. And he's a former chair of the Indo-US Report TB Consortium. I'm sure Professor Christopher will touch about the TB Consortium which is going on. His research interests are tuberculosis, COVID-19, allergy, asthma, COPD, epidemiology. And needless to say, he's a great researcher, and he's got a fantastic team in CMC Vellore, and he has authored more than 200 publications, 15 chapters in books, and delivered over 200 lectures. And we are eagerly looking forward to the topic. You can get started, Radhika, with the first talk.
Sure, sir. So now we'll just have the session for Dr. DJ Christopher. So the support team, if we can start.
Good day to you all. It's my pleasure to address you today on the risk for TB and its management in diabetics. Before I proceed with my lecture, I would like to thank Messrs. CIPLA for having organized this important event on an important condition, or may I say on important conditions, TB and its bearing on patient health. Before I proceed with my lecture, to the Indian Chest Society for prioritizing this important topic and having asked me to do this lecture. So tuberculosis and diabetes are old foes. It's not now that we know about it, but our ancestors knew about it. Indian physician Sushruta in 600 AD stated that phthisis frequently complicated diabetes. And also autopsy studies in 1883 showed the presence of TB granulomas in 50% of the diabetics. And prior to the insulin era, diagnosis of diabetes was a death sentence, and many people succumbed to the disease. Now, more importantly, the leading cause of death in these people was tuberculosis. Diabetes increases risk for progression from latent TB to active TB and also complicates treatment of active TB. There are delays in diagnosis for both diabetes and TB when they occur together. And globally, the number of people with diabetes is increasing. And so that has implications on the TB problem. We know that diabetics, especially when poorly controlled, cause a kind of an immunocompromised situation, which increases the likelihood of reactivation of TB. And also there's a dramatic increase in diabetes, and India is called the diabetic capital of the world, not something we can be proud about, but it's a reality we need to take cognizance of. And diabetics disproportionately affect the lower socioeconomic groups and ethnic minorities who also have a higher risk of TB prevalence. There are important treatment considerations. It is hard to treat TB in the face of poor diabetic control. And also, diabetes is a hidden epidemic. A quarter of people with diabetes don't know that they have it. With these background details, I will proceed to share about the natural history of tuberculosis. You see here a patient with tuberculosis coughing up mycobacteria and exposing a contact, who then may or may not get TB infection. 65% in fact may not get TB infection, whereas 35% may get infected. Of these, 10% overall in their lifetime may develop active tuberculosis. So those that do not develop infection are negative by tuberculin skin test, as well as quantiferon gold and other similar tests. And those that are infected are positive by these tests, but they are not all deceased in that sense. Sorry. So in this context, let's talk about two forms of tuberculosis: latent TB infection and active TB. Persons with latent TB infection are those who are positive by tuberculin or quantiferon gold, but they are asymptomatic and non-infectious. They are many of us, the normal people who have had an encounter with the mycobacteria, mounted an immune response, and have not managed not to get active TB disease up to that point. Now, latent TB, as I said, can be diagnosed by tuberculin test and quantiferon. Active TB, on the other hand, are people who are infected with mycobacterium that progress beyond latent TB, and they have usually significant quantum of mycobacterial TB, often actively multiplying, and they are invariably symptomatic, and they could be infectious and spread the disease. So India is the highest TB burden country in the world. The global annual TB incidence is about 10.4 million, of which India accounts for 2.8 million, the highest TB burden in the world. If you look at the quantum of TB, and this is a map, as you may recognize, but this is drawn not to scale, but this is drawn in proportion to the quantity of disease. So if you draw the globe with regard to the TB prevalence, you will see that India becomes probably the largest nation in the world. And many countries like North America dwindle in size in comparison. So if we look at the diabetic map, again drawn based on the quantum of diabetes in these populations, while parts of North America and other parts do pop up now and they have diabetes, but India still remains a large player. And so India has the dubious distinction of having a large amount of TB problem and a large diabetic problem to cope with. If you look at the WHO data, they say that 15% of TB cases worldwide are associated with diabetes. And India and China account for more than 40% of the global coexistent disease. And of course, India holds the highest number. Now, in terms of the prevalence of diabetes TB in India, there is data from several parts. I have picked up a few. The southern parts have the highest prevalence of TB diabetes combination. Puducherry, Tamil Nadu, then lower in Ahmedabad, Odisha and Punjab. So we do not know the explanation to this, but southern parts have reported a higher TB diabetes burden. Now there are plausible explanations for underlying mechanisms causing the DM and TB convergence. There's a compromised cell-mediated immune response due to uncontrolled hyperglycemia. And there's worsening glycemic control as a result of an endocrine-linked metabolic response to stress, such as to TB. So these are two facets of the problem. The immunocompromised situation predisposing to diabetes, and the endocrine metabolic situation that TB causes, which worsens the glycemic levels. Let's now look at some prevalence studies. This study is by Dr. Vijay Vishwanathan and team. They looked at the prevalence of diabetes and prediabetes and associated risk factors. Their target population was in the Chennai region. They covered Tiruvallur district and Kanchipuram district. And so their overall prevalence of diabetes among TB patients was 25.3%, of whom 9.3 studies by the newly diagnosed TB patients. Before they were diagnosed as they did not know they were diabetic, and 15.9% were known diabetic patients. And men had higher prevalence of diabetes than women, and this difference was statistically significant. Now, I want to share with you our study. It's a 10-year retrospective study of all patients diagnosed in CMC Vellore. It was a retrospective study looking at data from 2001 to 2011. And we had computerized hospital data to get all the information we required. And diagnosis of TB was made as per accepted criteria. So in all, we had 2,224 TB patients, of whom 1980 had plasma glucose and other values to diagnose diabetes. The mean age was 39 years, males were 71%, substantially outnumbering women. The type of diabetes, 83.9% had pulmonary TB, 58.1% were sputum positive, 41.9% were sputum smear negative. And 16.6% had extra, 16.1% had extra pulmonary TB. We looked at some interesting information, which I will share. We found that diabetics in the 29 to 39 kilo weight, which is the low body weight, the diabetics were significantly lower. So diabetics, only 6.2% had such low weights, whereas non-diabetics 16.3% had. So non-diabetics seem to be more prone for low weights. On the other hand, if you look at the 55 to 69 weight band, we found that diabetics were 42.3% in this group, whereas non-diabetics were only 29% in this group. And both these were statistically significant. So it seems clear that diabetics generally are on the overweight side compared to the other patients who are diagnosed to have tuberculosis. So overall, our diabetes prevalence in TB patients was 24%. In smear positive TB, it was 29%. Smear negative, it was 21%. And in extra pulmonary TB, it was 14%. At the time of diagnosis, 52 had known TB. 52% of the people diagnosed had known TB, and 48% were for the first time diagnosed as having diabetes. So known diabetics were 52, and not known diabetics freshly diagnosed were 48. This is very important information, and it reiterates the need to screen all TB patients for diabetes. So we looked at the number needed to treat to diagnose a case of diabetes, number needed to screen. So if you screen 4 TB patients, you will diagnose 1 case of diabetes. And if you take only the people who are not known to be diabetic, if you screen 9.5 patients, you would end up picking 1 case of diabetes. So this is extremely cost effective, and so again reiterating the need to screen all TB patients for diabetes. This is another study by Vijay Vishwanathan and team again. They looked at the effect of diabetes on treatment outcomes. So it is very important to see if diabetics differ in their response to treatment and cure. So they found that smear conversion at the end of 2 months, which is the intensive phase end, was 85.3% in diabetics, and 91.7% in pre-diabetics, and 96.6% in non-diabetics. So in other words, the sputum conversion was significantly delayed in diabetics. They still remained more positive at the end of 2 months. This is the average duration needed for sputum conversion according to their glycemic status. Again, diabetics took longer, 64 days to convert, pre-diabetics 62 days, and non-diabetics 61 days. And this also was statistically significant. So what seems clear is that diabetic patients take more time to smear convert. And if we may extrapolate that, we could say that they take more time for cure. This is another important study. The acronym for the study is EDOTS. It comes under the Report India Consortium. And this is again Dr. Vijay Vishwanathan and his collaborator, Dr. Hardy Kornfeld, who published this rather startling data. Of the 209 eligible patients whom they screened, 54.1% were diabetic. This is Chennai population. 54.1 were diabetic. And 21% had impaired glucose tolerance. And so it left only 24.9% who were normoglycemic. This is unbelievable. So barely 25% normoglycemic. The others having impaired glucose tolerance or diabetes. Again, new diabetics were 32.7%. So again, reiterating the need to screen all TB patients for diabetes. And non-diabetics were 67.3%. The study concluded that there's strikingly high prevalence of glycemic disorders in South Indian patients with pulmonary TB, emphasizing the need for urgent action to better understand and address the dual burden of TB and diabetes. This is a study done from our group in CMC. We looked at the pharmacokinetics of isoniazid and rifampicin in TB patients in both diabetics and non-diabetics. Now, the basis of our study is that there's increased severity of pulmonary TB and poor treatment outcomes. And so we wondered if there is low plasma level, which may partly at least explain the slower cure that we have in TB patients. So we looked at serial plasma concentrations of isoniazid rifampicin in patients with and without diabetes. And we also tried to compare the clinical response in terms of sputum conversion at the end of intensive phase, and also to identify other factors that may influence plasma drug concentration. So again, there were more male subjects than females, and the median age was 53 years for the diabetic group and 35 years for the TB only group. So the diabetic TB patients tend to be older. And then TB diabetes had a mean BMI of 21 as against 17 in the case of pulmonary TB only. Again, diabetic TB patients seem to have a higher BMI. The average per kilogram dose received was lesser in TB diabetes group compared to the TB only group. We concluded that there was no significant difference in pharmacokinetics of isoniazid and rifampicin between the groups. The BMI had inverse relationship with maximum drug concentrations of isoniazid and rifampicin. In other words, higher the BMI, the lower the maximal drug concentration. Pulmonary TB diabetic group showed a trend towards poor treatment outcomes. They had lesser weight gain and poorer sputum conversions despite reaching normal drug concentrations. So we concluded in this study that further studies should address higher anti-TB doses in TB diabetic patients with the hope of improving clinical response. In other words, is the dosage, does it have to be the same for diabetic and non-diabetics? In fact, should diabetics receive higher dose? There's definitely scope for further research. This next study is looking at screening for TB patients in a diabetic clinic. So we have shown studies that looked at screening TB patients for diabetics. Now we are screening diabetic patients for tuberculosis. This was again from our center in CMC Vellore. So of the 1,000 patients enrolled, 43 were known diabetic, and 5% of them had symptoms suggestive of TB, and 1% was diagnosed to have active TB. So about 10 in 1,000, nearly 1,000 patients. So if we screen 1,000 patients, we may diagnose one case of active TB. Again, we found that TB diabetic patients are older and had longer duration of disease and had poor glycemic control. 48% were found to have latent TB. We not only studied active TB, but we also studied latent TB. And 48% is high, so it is clear that diabetic patients have a higher degree of latent TB as well. So this is data of how good our screening of patients diagnosed to have TB actually is. So a total of 6,393 patients were referred for screening for TB from a diabetic clinic, of whom 2% had positive on TB symptom screen, and of these, of these 128 were referred for investigations, and the number of patients who reached the center for TB diagnostic testing was only 50%. So we are not doing well at all. We are identifying lesser patients with symptom, and many of them don't even go for screening. So this communicates the sad state of affairs, and this certainly should improve. So what is the protocol for screening? We need to screen patients, diabetic patients, once or twice a year, and ask all TB patients whether they have had TB diagnosed in the past, especially in the last 6 months or 3 months or whatever time they have seen you last. If they have not been diagnosed as TB, you screen them with symptom questionnaire. Ask them about history of cough, weight loss, fever, and see if any of them have features of TB and refer them for appropriate diagnosis. We know the NTB strategy, that there is a hope that we can end TB as a major problem by 2030. And India has advanced this time point to 2025. It's a lofty goal. Will India really achieve this? And what is the significance of TB control in this objective? This is a mathematical modeling study looking at the impact of TB control. So this study looked at 13 countries with high TB burdens. So they concluded that diabetes is increasing. So if it continues to increase at the same rate, the global incidence of TB is dropping, so it will continue to drop at about 8.8%. And the TB mortality may drop at 34%. If now we intervene and stop the increase of diabetes, then the global incidence of TB will drop by 20.3%. and the TB mortality by 42.7%. If on the other hand, the TB problem, which is increasing in the low middle income countries, increases further, then the global incidence will not drop. It will actually increase by 7.8%. And of course, there will also be increase in TB mortality. So that's a very grave sign for us. We are looking at controlling TB by 2025, 2030. And for that, we need to substantially reduce the diabetic population. And this is linked to the target of reducing TB. I want to just cover a few points about treatment of TB diabetes. Now, prevention of TB in persons with diabetes. So diabetics should be screened for latent TB. So we can do tuberculin or interferon gamma release assay such as quantiferon gold at the time of diabetic diagnosis, or if it has not been done, subsequently. And anyone who is found to have latent TB infection should be encouraged to have isoniazid prophylaxis. And then patients who are given isoniazid should also be given vitamin B6 to make sure that they do not develop isoniazid-induced neuropathy. Treatment of TB in persons with diabetes. We should ensure that TB treatment is appropriately adjusted in patients with diabetes We have to check creatinine for diabetic nephropathy because we need to adjust the dose of drugs that are excreted in the kidney, such as pyrazinamide and ethambutol. And also we have to give B6 to prevent isoniazid-induced peripheral neuropathy. We give this on all patients, but in these patients, it needs to be given with more care. Now, I want to close by sharing several clinical management questions of combined TB and diabetes. Research has to address these questions, and we do not have the answer. Should we adjust TB treatment in dose or duration for diabetics? Should we follow TB diabetes patients after completion of treatment given the higher risk of recurrence? How important is glycemic control for improving TB outcomes in TB diabetes? Should we use insulin or metformin or other glucose-lowering medication for glycemic control? Is there more hepatotoxicity in TB diabetes? Should we monitor TB treatment more intensely in patients with TB diabetes? What drug-drug interactions are relevant for treating combined TB diabetes? Can we explain the higher mortality seen in TB diabetes in some settings? Should we consider adjuvant antiplatelets or lipid-lowering treatments? How should patients with TB diabetes be counseled regarding lifestyle changes? How should care for patients with TB diabetes be coordinated? How should diabetes care be continued after completion of TB treatment? So these are all key questions that I hope studies in future will address. With that, I want to close my lecture. I hope I have convinced you about the importance of the TB diabetic problem and the importance of the need to address both of them in tandem in order to ensure best patient outcomes. Thanks once again for this opportunity to speak to you.
Thank you, Professor Christopher. I think you have highlighted the importance of this word called bidirectional screening. That is, screen TB patients for diabetes and screen diabetic patients for TB. We'll discuss more about this in the Q&A session. Now, and most of your questions on which you showed in the last slide will be answered by Professor A.K. Das. It's my privilege to introduce Professor A.K. Das. Can I have his CV? Yeah, so Professor A.K. Das, who's several decades senior to me, is a consultant endocrinologist at the Department of Medicine and Endocrinology at the Pondicherry Institute of Medical Sciences, PIMS Pondicherry. He was a former dean, a medical superintendent, and a professor of medicine in JIPMA, which is an institute of national importance. He was a co-chair of the ICMR INDIAB. He is the co-chair of the ICMR INDIAB study. He's a chair of the Diabetes in the Young Registry, and he's a very respected member of the Research Society for Study of Diabetes, of which I happen to be the National Vice President now. We have a lot of respect for Professor A.K. Das. He was the past National President of API, which is the largest body of physicians in India, and also the RSDI. And he was a past Dean of the Indian College of Physicians, which is an arm of the API and which consists of top physicians in the country. And Sir has got fantastic research acumen, and he's got 163 publications in national and international journals. So over to most respected Professor A.K. Das, sir.
I'm extremely delighted this morning to be here to speak about a very most important and contemporary challenge, the management of type 2 diabetes mellitus in tuberculosis. I have a small agenda which I have brought here. We'll discuss why treat this huge burden of TB and diabetes mellitus, a lethal combination of both. What is the importance of bidirectional screening and proper management? What is the special clinical profile of diabetes mellitus and tuberculosis? And what are special clinical and extra features? Principles of management the interaction between the anti-TB drugs, the anti-diabetic drugs, and the other drug-drug interaction that we use here. The treatment centers around lifestyle, oral anti-diabetic drugs, insulin, and rarely we take recourse to GLP-1 RAs. We'll discuss the management issues of diabetic comorbidities like diabetic kidney disease, diabetic liver disease, and also one diabetic complications, say like diabetic HIV with tuberculosis. We'll draw some conclusion and show that diabetes mellitus and tuberculosis today is a great public health concern. Either we have to treat, the imperative choice is to treat them adequately. The diabetes and tuberculosis, called double trouble, or two endemics together, are called syndemic. There's a strong epidemiological evidence demonstrating the coexistence of both. The endemic in developing countries is a great concern because the type 2 diabetes is an epidemic and TB is an epidemic. You know, diabetes and tuberculosis epidemic has comorbidities that include old age, sedentary occupation, cigarette smoking, alcohol consumption, both low and high BMIs, HIV co-infection, weight loss, hypertension, and family history of diabetes or family history of tuberculosis. This cartoon beautifully shows that TB has a high burden in at least 22 countries in the WHO list. China, India, Brazil are few of them. And we have 15% TB cases worldwide, which are associated with diabetes mellitus. And in India and China, it is almost 40%. India alone accounts for the highest number of adult TB cases along with diabetes mellitus. Coming to the global burden of diabetes mellitus patients with pulmonary tuberculosis, the WHO has given that that we have a very high prevalence of diabetes in patients with tuberculosis as shown here. And you know, if you come back to India, we have a prevalence of 16.06%, almost second in rank in the entire globe. Dear friends, the combination of diabetes and tuberculosis is not 1 + 1 = 1, it's 1 + 1 = 11, because diabetes increases the risk of low respiratory infection, especially tuberculosis, by 1.5 to 7.8, almost 8-fold. And the RR is almost 3.11 of contracting tuberculosis. You know why? It is because of the relative immunocompromise, hyperglycemia, cellular insulin deficiency, dysfunctional macrophage, ketosis, all this interfere with the bactericidal effect. Further, diabetes mellitus alters the pharmacokinetic of several anti-TB drugs, and the altered plasma levels due to difference in absorption, distribution, metabolism, and excretion. We have lower plasma level of the anti-TB drugs, which is a great concern in the tuberculosis patients. I must tell you that the diabetic patients who develop tuberculosis has atypical radiological imaging, like predominantly involving the lower lobes, often with cavitation. Poor glycemic control is a significant risk factor for low rate of sputum conversion. This must be remembered. And there's a higher likelihood of developing both MDR and XDR tuberculosis. Further, TB bacilli may have an effect on the diabetes and the poor glycemic control. Now, this impairs the hepatic glycogenesis, increased glycogen lysis and gluconeogenesis, and impaired insulin secretion by direct effect on the pancreatic islets. And there is also a diabetogenic effect of rifampicin and INH in a different manner, which I'll show in a minute. I have brought this small chart cartoon to show the mixed audience here that we diagnose diabetes when the random blood glucose is more than 200 on 2 occasions without symptoms, or 1 occasion with symptoms of the osmotic symptoms like PPP, polyuria, polydipsia, polyphagia, or anything else. Or if we have a fasting of 110, WHO says 100 to 110, but 125 is the highest of the fasting blood glucose. If the fasting blood glucose more than 126 and the postprandial more than 200, diagnosed diabetes. The fasting is normal, but postprandial between 126 and 109, we call it impaired blood glucose. Dear friends, this is an algorithm which shows the bidirectional management of diabetes and tuberculosis. Now we have the how to diagnose diabetes, how to screen and treat with insulin, metformin, other OHs, and most important lifestyle is shown here. and how to control the blood glucose by repeated monitoring, and what the public health measures are given here. Similarly, patients with tuberculosis, we have to have screen positive. We have microbiological confirmation with sputum microscopy, gene expert, which will be told by Dr. Christopher, I'm sure. And tuberculosis treated with the anti-TB drugs. We'll come back to a minute. I want to show here TB patients needed to be screened for diabetes mellitus, because if you screen 4 people, you will find 1 diabetic. That's the prevalence of diabetes in tuberculosis patients. Now, coming to the clinical profile, which one must remember, that there are some peculiarities. Higher rates of poor outcome. There is weight loss, fever, dyspnea, and night sweats, and delayed recovery of the body mass and hemoglobin levels in spite of recovery. The clinical features, they're slightly elderly diabetic with tuberculosis, more than 40 years, cavitary pattern in the chest X-ray, more side effects of the anti-TB drugs, hospitalization is necessary sometimes at the time of diagnosis. They have comorbid hypertension and obesity usually. Now, more type 2 diabetes patients with tuberculosis develop cavitation, 82% vis-a-vis 60%. More often the lower long pills, 29 versus 3. More multiple cavities, 25 versus 2. Lower leukocyte count. And the multiple regression analysis has shown that being a diabetic was the most important factor in determining the lower lobe involvement. The relative risk of LTBI stands for latent TB infection in patients with diabetic versus non-diabetic, is an old study which has shown that, if you find the TB context, the LTBI, the latent TB infection in type 2 diabetes is about 8.4% vis-a-vis 4.3%. The diabetic patients with tuberculosis have high mean age, a family history of diabetes, history of hypertension and obesity. Non-diabetic TB affects upper lobe, where it affects lower lobe. Diabetic tuberculosis, extensive lesion, greater involvement of the parietal pleura, confluent lesions, and cavity formation. Dear friends, what are the factors that affect effective glycemic control in a diabetic patient with tuberculosis? Drug therapy. One must look for the adverse effect, drug-drug interaction, and the weight gain that occurs during treatment because of tuberculosis treatment. And active tuberculosis inflammation leads to weight loss, loss of appetite, and it gives to insulin resistance. And there's a patient behavior like variable food intake, physical inactivity or activity, treatment compliance. All these are important issues. And also the health system, the accessibility and affordability of health services and collaboration between both these experts are vital, which I'll come back in a minute. Now, if you come to the approach to the glycemic control, what are the factors that we must take care? Severity and prognosis of a given patient's tuberculosis disease, risk of adverse events such as hypoglycemia, like kidney disease, diabetes with a hypoglycemic propensity, duration of diabetes, long duration, comorbidities, aged patient, patient capabilities, treatment preferences, available resources, they all influence the glucose. Friends, if you see the difference between TB alone and diabetes with TB, they are usually adults and aged, more in men, lesser body weight loss, but more of breathlessness, more of fatigue, and much lower expectation. Only pulmonary and very few extrapulmonary involvement. HbA1c is higher, and the difficulty in diagnosis. How do you diagnose? The management goals are very simple. We have to maintain blood glucose level between 120 and 150, HbA1c less than 7. The most important, the lifestyle. Lifestyle measures should be tailored to the individual patient needs, like increased protein intake, who have significant weight loss, weight reduction if the patient is obese, appropriate intake of minerals, vitamins. Vitamin D supplementation has shown to improve TB outcome. Vitamin B6, B12 supplementation, vitamin A supplementation for the immune response, mild to moderate physical activity, alcohol cessation, smoking cessation, and this lifestyle modification must continue even beyond the disease. There's a good role of medical nutrition therapy and pulmonary rehabilitation therapy, and of course a great value of patient education, and also the services must be decentralized to be available. And of course the patient must be taught how to self-monitor blood glucose. About the diet, the carbohydrate about 50 to 60%, protein 15%, and fat about 30%. We have to rotate the oils, cut down the saturated fatty acids to less than 10%, avoid the hydrogenated vegetable oils, and foods with low glycemic index and lots of fruits, leafy vegetables, nuts, grains, whole grains, pulses, legumes are indicated. Dear friends, the mainstay of pharmacotherapy of diabetes and tuberculosis is insulin. Recommended in all patients of tuberculosis, potential benefits are its anabolic effect, low potential for drug interaction, and can be given at any stage of diabetic complication, any stage of tuberculosis complications. If the HbA1c more than 9, fasting blood glucose more than 250, we start it right away. We also start it right away when the TB patients has ketone bodies, symptoms of hyperosmolar state, or in a catabolic state with PPP symptoms. We start right away, and dose adjustments are necessary. Metformin is recommended only in less severe cases or those who cannot take or not willing to take insulin. The potential benefits are low drug interaction with anti-TB agents, and there is some immunomodulatory effect, which will come back in a minute. Now, discontinued metformin treatment if there is an abnormal liver function test more than 3 times of the normal enzyme levels, estimated GFR if it is less than 30. Dear friends, the other oral anti-diabetic drugs we less use because we avoid drug-drug interaction. Shorter-acting sulfonylureas such as glyclazide and dipyzide can be used, and the risk of infections with DPP4 and especially SGLT2 inhibition should be considered. Now, we'll come back to the minute. What is the reaction between rifampicin and sulfonylurea? Rifampicin increases the hepatic metabolism of all sulfonylurea derivatives. Rifampicin also substrate as metformin for the organic cation transporter. Therefore, rifampicin enhances the glucose lowering effect of metformin. So the rifampicin has an effect on the sulfonylureas because it increases the hepatic metabolism of all sulfonylureas, and metformin, it makes it more active. No effect on the DPP4, SGLT2 inhibitor, on GLP-1 RA. Now, the oral hypoglycemic agents in tuberculosis are shown here, and what is their importance in tuberculosis? Biguanides, the effect on the weight, it produces weight loss. It can produce very rarely. The Cochrane analysis says there's no lactic acidosis today. There is enhanced effect if you use it metformin, and you know, sulfonylurea can produce weight gain and more of hypoglycemia, decreased serum concentration because of enzyme induction. TZDs, weight gain, hypoglycemia, decreased serum concentration. DP4 weight neutral, alpha glucose inhibitor weight neutral. They have the GI effects, no interaction with the anti-diabetic drug. SGLT2 inhibitors can produce weight loss and produce infection elsewhere. And you know, there's a decreased concentration of dapagliflozin by a UGT-A19 mediated glucuronidation. So one has to be careful if you're using this drug. Now, rarely we use GLP-1 analog. I've just brought it for completion. We have the injectable, and today we have the oral semaglutide also, which is available. Insulin therapy has to be aggressive, is the preferred and the safest modality of treatment. The choice of insulin are basal, premixed, or prandial. I brought the cartoons of all the therapy. We can give basal, long-acting insulin like Lantus, and multiple bolus injection with the food, breakfast, lunch, and dinner. We can give rapid-acting insulin prandial after each food. One can give premix when one can control giving 2 injections. One can give intermittent insulin like NPH, which is usually used twice a day. One can use short-acting insulin, multiple doses, and there are many ways of controlling it. Dear friends, you know, the algorithm of insulin treatment is very simple. Usually, we initiate with basal insulin with metformin or without any other oral drugs. We give, if it is less than 8, we start with usual 0.1 to 0.2 units. If the body weight is more, we start with 0.3. And there's a fixed regimen where we increase by 2 to 4 units daily. And our target is to maintain blood glucose 120 to 180 maximum. If the glycemic goals are not met with insulin or metformin, we may add other drugs like SGLT2 inhibitors, DPP4, or even GLP-1 RA if the glycemic goals are not met. And also we can give prandial insulin, that is the short-acting insulin, 10% basal dose before the largest meal. we normally change over after some time to premix insulin twice daily because we divide the current basal dose 2/3 in the morning and 1/3 in the evening. Now, metformin has some other advantage that it inhibits the growth of Mycobacterium tuberculosis because of its action to the activated protein kinase AMPK. In 2 separate human cohorts, metformin treatment was associated with increased MTB turnover, MTB change to negativity, and decreased disease severity. Metformin can be used as adjuvant therapy. Now, oral hypoglycemic agents in severe tuberculosis, I repeat, in severe tuberculosis are contraindicated. Insulin has to be given. Rifampicin, potent hepatic enzyme inducer. So sulfonylurea, biguanides, it has effect. Isoniazid, contrast to metformin, inhibits the metabolism of oral hypoglycemic agents and may lead to the increased level of the oral hypoglycemic drugs. Now, the diabetes management has to be aggressive. Insulin therapy is the treatment of choice. Insulin requirements are high to begin with, but falls after some time. And once glucotoxicity is corrected, insulin requirement rise again as the appetite returns to normal with treatment. Sick patients should be tested for ketonuria, but TB does not produce ketosis ordinarily. Rapid-acting analogs like aspart can control the ketonuria. So therefore, treatment challenges managing diabetes with tuberculosis. Now, TB worsens the diabetes, the glycemic control. Maintaining normoglycemia is a challenge. One can do it with oral hypoglycemic or insulin. The preferred drug is insulin. Whether tighter glycemic control, more effective in the anti-tubercular drug action, and faster clinical radiological resolution is not yet known. But there are studies that in sputum positive cases, insulin use has produced sputum negativity. An average patient will need about 1 unit per kg per day of insulin initially. You can give 60% bolus and 40% as the basal insulin. And once the patient improves, it can come down to 0.5 units. Dear friends, we use insulin in all the cases. There are many benefits, but we can use metformin in less severe cases. And you know, the tuberculosis management will be spoken by Dr. Christopher has been. So the usual treatment of the chronic kidney disease that one has to modify the dose of EMB and PZA. But coming to my part of diabetes management with comorbid chronic kidney disease because of diabetes, insulin is the drug of choice if there is DKD plus tuberculosis. Careful dose titration to avoid hypoglycemia. Metformin to be avoided if eGFR is below 30, and regular monitoring of the protein at the kidney function is advisable. If somebody has chronic liver disease, now delay or defer TB treatment until acute hepatitis is resolved. Discontinue hepatotoxic drugs, anti-TB drugs like INH, rifampicin, PZA. This will be taught by the Dr. Christopher. I will not go in details of it, but I must say that in presence of the liver disease, the drug of choice is insulin again. Insulin recommended for treatment of diabetes with comorbid chronic liver disease. Insulin requirement may be higher in patients with impaired hepatic deficiency, lower in patients with decompensated liver disease. Metformin can be used with patients with stable liver disease, that is child PUG score less than 7, should be avoided in cirrhosis patient. Cessation of alcohol is very important. Now coming to complication, I have taken one important complication. Now, if somebody has HIV, one has to diagnose by using the various tests like GeneXpert, MTBRIF assay, etc., the interferon gamma release assay that will be discussed by the pulmonologist. Now, HIV testing is recommended in all patients with presumptive tuberculosis. What is most important? If somebody has HIV, tuberculosis, and diabetes mellitus, the treatment with insulin is what is necessary and the gold standard. And we have to avoid metformin in the cachexia patients. Before I close, I must tell you the escalating prevalence of both diabetes and tuberculosis in India and the syndemic is a growing concern for our country. But what we need today is a coordination with the government services of communicable disease like RNTCP and NCD like National NPDCS, National Program for Control of Diabetes, which is lacking. Although these independent bodies have efficiently raised awareness of tuberculosis and diabetes as individual issues, the limited understanding of about the diabetes and tuberculosis comorbidity among patients and the healthcare professionals. The lack of awareness that diabetes mellitus and tuberculosis is separate kettle of fish is a very great entity can seriously jeopardize treatment outcomes in both diseases. Dear friends, I'll end by saying an example that we lost one American president in 1941 before the TB treatment came. But we lost another American president because of hypertension, and the treatment of hypertension was available. And the debate was going on by whether the hypertension to be treated or not to be treated. And the president had cerebral hemorrhage. Dear friends, I must appeal with a great passion that treating diabetes mellitus and tuberculosis is a must. We have active treatment for both. And today's, the imperative choice is to treat diabetes and tuberculosis effectively. A little effort will produce great results and change the destiny of these patients. Thank you very much, dear friends, for a very patient hearing. We'll have discussion later on.
Thank you, Professor Ekedas. I think in your characteristic style, you have highlighted the entire gamut of TB and diabetes, focusing more on diabetes. Allow me to just show one slide, because I think this audience must know that there is a Report India consortium of which Dr. Professor Christopher and me are members. You can see Professor Christopher sitting here. I'm not able to show my slides, and his colleague Dr. Bala Mugesh behind in the last row. So we have an Indian counterpart and an American counterpart. This has been funded by the NIH and DBT, and we have finished 5 years and we have gone to report phase 2 now. And this was a photograph taken during one of the report meetings. Last 2 meetings or last 3 meetings, we've been having it as physical, virtual meetings. But the Report India consortium has come up with some fascinating data which has been published. CMC, Vellore, JIPMER, our hospital are all parts of it, and the NIRT. So only one more slide I'll just show, and I don't know where the thing is, the pointer is. See, the point, this is from the report data produced by Pawan Kumar and NIRT group and our group. You can see that when you have TB and diabetes and TB, if I go to the full slide, maybe, you can, I'll just take 10 seconds, 30 seconds to, you can see diabetes and TB in the violet color. And you can see that the expression of the genes which are responsible for cytokines is much higher. You see more reddish color in the TBDM group. And also you see this is the TBDM group, the gray color. You can see more red color. So you have both if you look at the mRNA profile or the cytokines, you measure it, you will find that when you have a TBDM, it manifests more. And one more last slide. When you talk about treatment, you should understand this once again by Pawan Kumar and colleagues from NIRT using our data. You can see that pre-ATT, month 2, month 6, and even month 18, you can see once again TBDM is marked in this orange color. You can see that the inflammation persists up to 6 months. So you should not consider somebody who's finished 6 months as completely cured. You can see that the expression of the cytokines, the inflammation is still persistent in people who have diabetes and TB compared to TB alone. And that's all I have to show. And
very important points, Vijay, very important points, and a lot of carry homes in this slide. Thank you.
Yeah. So we will go on to the questions without, in the interest of time. The first question is to Professor Christopher. Which lobes are, and this came from the chat box, which lobes are most commonly involved in diabetes and TB? So do you have any opinion on that?
Yeah, so I think if you take the just for what is more, what is less, it will continue to be upper lobe. But there's some literature to say that perhaps other locations like lower lobe are more high in diabetic patients compared to non-diabetic patients. So if you take overall, upper lobe disease will be predominant, but the lower lobe involvement is likely to be more in diabetic patients than non-diabetic patients.
Okay. The second question is, if somebody has got fungal infection and diabetes, how do you differentiate fungal infection from a tuberculosis lesion? This was another question to Professor Christopher.
Okay. So if they now, fungal infection of the lung, typically, if you talk about an invasive disease, occurs in the setting of immunosuppression. So normal people may not develop invasive disease. But the scenario you are talking about occurs when people with some kind of cavity, usually a pre-existing cavity, like heel tuberculosis or cavity due to some other reason, and that is colonized by a fungus. And then so they have not acute fungal infection, but a kind of a subacute infection. So the way to make that out is, the way to rule out tuberculosis is easier. Even smear, expert, and culture will easily rule out tuberculosis. But to diagnose fungal infection is a little more challenging. The ideal test to distinguish the two will be a bronchoscopic evaluation. You go into the cavity or close to the cavity as possible, flush some saline, take a bronchoalveolar lavage, send for fungal studies, send for TB studies. You will usually get the answer.
Thank you, Professor Christopher. One last question to you before I ask Professor Ekidas. Is it safe to give INH monotherapy? Will it not produce resistance? So should we always combine? So you were talking about, I think, INH monotherapy in latent
prophylaxis.
TB. Prophylaxis, yeah.
Yeah. So isoniazid, prophylaxis for TB is a contentious area, and what is suitable for the developed countries is not suitable for us. We use much less prophylaxis than people overseas use. Anyway, there are multiple regimes, and many of them are isoniazid based. There are alternate regimes. There's a rifampicin regime which we frequently use, which is 4 months of daily rifampicin alone. And there is a rifampentine and high dose isoniazid weekly regime. That is probably the best regime we have available. It's a once weekly treatment for 3 months, I think. So these are the regimes. Now, isoniazid daily is a regime which is accepted by WHO and globally. But if you say whether, the only argument that you can make is that in our country, the primary resistance to isoniazid is relatively higher. So whether it is better to give a rifampicin-based prophylaxis, probably. So although there is no proof, it holds to reason that we can give a rifampicin-based prophylaxis, which is 4 months of daily rifampicin.
Thank you.
Yeah, Vijay, small question. Can I? Very interesting, and I may not get Dr. Christopher so easily. Dr. Christopher, I want to ask you that how would you encounter in Indian TB patients, histoplasma and the Cryptococcus neoformans? Aspergillosis, you rightly pointed out in the cavity infections, but do you also encounter histoplasma and cryptococcal neoformans?
We do, but extremely rarely.
Yes, but thanks. That's
rarely.
It. And taking cue from Vijay's question, Dr. Christopher, we are very afraid of giving isoniazid alone because we are taught, maybe Vijay is an authority now, we are taught that isoniazid alone will confer more resistance. Vijay, am I correct? That was the teaching.
That was a question which is asked. So
yeah, but Vijay, that is the usual question. We teach our students, never give isoniazid alone. But now our doubts are clear. And rifampicin for 4 months is better. Am I correct, Christopher, sir?
Yes, that's definitely more reliable and probably better in our country.
Thank you. Yes, Vijay, you can come back to
one question to Professor Das. How do you, in the chat box, how do you manage TB in the rural areas? I'm sorry, how do you manage diabetes in the rural areas?
A fantastic question. Vijay, I'll be very brief in interest of time. Insulin is not a must. We can manage diabetes in the rural areas by the oral anti-diabetic drugs. And all oral anti-diabetic drugs can be used, starting from short-acting sulfonylureas like glycoside and glipizide. One can also use gliptins, and one can also use SGLT2 inhibitors. Now, DAPA has gone off patent. It's easily available. It's a very effective drug for tuberculosis. We know the rural areas have two challenges, Bijay. One is the hypoglycemia propensity, and the other thing is weight gain. But the drugs we do not produce hypoglycemia, like short-acting sulfonylureas. Of course, one has to be careful where they have interaction with the rifampicin. But I don't think that will be a great clinical problem with short-acting one. The glibenclamide and long-acting ones can produce difficult issues. And short-acting are safe. Metformin is very safe. I would recommend metformin, Vijay, in rural areas, because you just give it and forget about, like Indian petroleum advertisement, fill up and forget, because metformin will not produce any hypoglycemia. Christopher sir, we use it left, right, and in the middle. It will not produce any hypoglycemia, no weight gain, and of course, gliptins and SGLT2 can be used. And monitoring blood glucose is an issue in the rural areas, but there is no substitute. Urine examination has been given away. So once in a while, they can go to the primary health center or ASHA. We have empowered with the glucometers. They can look at the blood glucose level, because diabetes cannot be treated without blood glucose estimation at least once a month, once in 15 days. But the drugs I have given do not usually produce hypoglycemia. Vijay, what's your comment?
I think glipizide is forgotten. We used to have a beautiful product, glipizide, earlier. And even the non-sulfonylurea secretagogues like pripaglinide are not used. But if you're talking about DPP4 inhibitors, vildagliptin, you might be a little careful because liver function.
Absolutely.
So I think glipizide is one, and in the RNTCV program, that's what they, for instance, the TB units in Chennai mostly use glipizide. And metformin.
The company is not promoting because there is no money in it, but glipizide is a wonderful drug. And you know what we call it, Vijay? Christopher sir, we call it oral insulin. Take a pill, take a pill. It is very short acting, no hypoglycemia, and brings down blood glucose. I think Vijay will agree with me. That's why he has put it in the South Indian guideline. Thank you, Vijay. So to cut a long story short, glipizide, the available, cheap, affordable, appropriate SGLT2 in our country today, like DAPA, metformin, should form the mainstay, and they do not produce hypoglycemia.
One more question. Can we go on for another 1 or 2 minutes?
Yeah, we can go.
We have one question. How do you elaborate? How do you make a diagnosis of latent TB and the validity of the drugs? One question in the chat box I didn't understand. Diagnosis, you have already talked about it, but validity of the drugs I didn't quite understand.
Latent TB, I think Christopher sir will answer. Yes. Yes, sir.
Dr. Vijay, is the question how to diagnose latent TB, which I covered?
Diagnosis of latent TB is one question.
Right.
And the same person has asked, and the validity of the drugs. I didn't understand what he meant by that.
Right. Okay. So diagnosis is historically by tuberculin skin test. It is still not abandoned. It is still holding its own and it is still in use. But more expensive and technically little more demanding is quantiferon, TB Gold, ELISpot. So these are the other tests that diagnose latent TB. So when to use it, I think we should use it in high-risk settings where you consider prophylaxis. It should not be just randomly used somewhere for nothing. It should be with a view to consider people for prophylaxis. Now, once you decide to give prophylaxis, let us say immunosuppressed patient, somebody on steroids, someone with renal failure and so on, you should choose an optimal regime, as has already been alluded to in our country. So there are several regimes available, but we prefer rifampicin-based regime, although there is no specific proof to the fact that it's superior to others. We prefer rifampicin-based regimes, but any regime can be used, really. I hope I've answered the question.
Yeah. Professor, we're talking about extra pulmonary tuberculosis. We're not covered it in this forum versus the pulmonary TB. So when you're managing diabetes, will you be more intensive in TB spine or TB intestines or whatever, compared to pulmonary TB?
Yeah, I think, Vijay, that's an excellent question, because we encounter brain tuberculosis like meningitis, spinal tuberculosis, and also encounter bone tuberculosis and bone and joint tuberculosis, and of course urogenital and GI tuberculosis. Now, the bottom line there is that the diabetes has to be adequately controlled. And the duration of treatment for this, for the meningitis, I mean, we know at least for the 12 months, 9 to 12 months. And the people who have spinal tuberculosis without any surgical intervention can be 9, 12, up to 18 months. I think Christopher Savage here, he will correct it. And for lymph node tuberculosis, we give for 6 months. My point was, Vijay, that when you give such a duration of anti-TB drugs, longer duration, sometimes who has got the bone tuberculosis, we also give at least for 12 months or beyond. One has to be careful to continue the anti-diabetic drugs effectively. At the same time, one must be careful about the weight gain which occurs in these patients. So the outcome of extrapulmonary tuberculosis, which are really severe tuberculosis, meningitis, spinal tuberculosis, the bones and joint tuberculosis, intestinal tuberculosis, also depends upon the outcome of the diabetes. So effective control for the whole duration of treatment and beyond. I think that point Christopher made, that the management of diabetes beyond tuberculosis treatment is over, is also an important issue.
Before I hand over to Sipla for the concluding remarks, if Dr. Christopher is available, is there a difference in the management of TB in people with diabetes and without diabetes? Would you look at something beyond DOTS therapy or something like that?
Very, very
important. People with TB versus people without, people with diabetes versus without diabetes.
Yeah, good question, Vijay, and it's a challenging one to answer. So what is fundamental for with and without diabetes is adequate doses. Am I audible?
Yes.
Yeah.
Okay, sorry. So what is imperative is the correct regime in adequate doses. I think in diabetes particularly, we should be cognizant of giving them the right and adequate doses weight-based, because one of the fears with diabetes is whether the serum levels they achieve is lower than the other people. And then the last one, which is a little contentious, is extension of duration of TB. I think you had very nicely showed that inflammation persists even at 6 months when the treatment is completed. So there is a case for extension. So how we would go about that in a programmatic situation is, if the patients delay in sputum conversion, then we would say, okay, we can then prolong the duration of TB treatment. So I think these are some of the, and again, we have to understand that anti-TB drugs reduce appetite. That will impact diabetic control. And again, there are interactions between rifampicin and anti-diabetic drugs. Thankfully, insulin and metformin, to the best of my knowledge, do not get affected by rifampicin. So they are safe to use. And of course, finally, coordination of care. TB is managed by somebody, diabetes by somebody else. I hope we can manage basic TB and basic diabetes by the same person. But even if they are managed differently, we should ensure that we coordinate well and both are optimally controlled.
Vijay, I have a small question to ask Christopher. Vijay, can I?
Yes, sir. Certainly.
I think this stems from what we discussed some time back. From the time of Dr. Singh's paper, then Leo's paper, and many other papers which gave a place of pride to metformin. And even though metformin has some interaction with RMP, what Dr. Christopher said, we have never seen anything significant with that interaction, Christopher. Now, but the metformin has been hailed as a drug which reduces mortality. Most important, takes care of the inflammation, which Vijay referred to, and also helps in converting sputum positive to sputum negative in a couple of months' time. And beyond that, it has also few other benefits, like it has immunomodulatory effect between the autophagy and the lipophagy, and we'll not go details of that. So I give metformin either as the primary therapy or an adjunct in the diabetic patients that I see with tuberculosis in PIMS and in JIPMO. So I would like to have your take on this from you, and then from my dear friend Vijay, my younger brother, his take on that. But Christopher, you first. Do you think metformin is a drug which can be of benefit, taking you from what Vijay had asked you?
Sure. So I think you raised a very important aspect which we did not cover in both of our talks, which is the potential anti-tuberculous effect of metformin.
Yeah.
Right. So that you covered it very nicely. There is evidence to say that it facilitates or it augments various TB improvement parameters.
Absolutely.
So that is another additional reason that enhances the case for using metformin when you use oral drugs. Our first choice for oral drugs is always metformin, and we have found that it goes well. So I hope I've answered your question.
Yeah, thank you very much. Christopher, you are fabulous. Over to Vijay, my dear friend Vijay.
So there is one study in the United States which is giving metformin to reduce aging. So
yeah, exactly.
so aging, so you age less, slower if you take metformin. All the guidelines, AAC, American Association for Clinical Endocrinologists, have put metformin first.
Yeah.
Whatever the drug, the SGLT2 inhibitor, everything comes after metformin.
Absolutely.
Add on to metformin. So far, no guidelines has knocked out metformin and put something above metformin as of today, except one guideline from Europe. Nobody has done that. So metformin is still the mainstay of treatment for diabetes, TB or no TB. So I would like to thank Cipla for, we always talk about diabetes and kidney and diabetes and heart. So much of emphasis is given. But today we have talked about diabetes and lung. So I would like to thank Cipla, who are the pioneers in respiratory therapy, for thinking of this topic, diabetes and the lung. And I would like to hand over to Dr. Radhika Joshi for concluding.
So much, sir. Firstly, thanks to both the speakers for beautifully explaining and very simply explaining it. It was a learning for me as well. I have taken a lot from this session today. And a very big and special thank you to Dr. Vishwanathan for wonderfully moderating the session. It wouldn't have been possible, sir, without you. And to the ICS team also, a very, very big thank you for this initiative and collaborating with us. It really means a lot. We're extremely grateful. And to the audience for joining on a Sunday morning at 11. A very big thank you to all the audience as well and sending in your questions. I hope we were able to justify and answer your questions as well. So with that, a very big thank you to all the panelists and to all the audience who joined in with us today for this session. Thank you so much.
Thank you so much. And we meet, and I think we should have several more meetings on diabetes in the lung.